Welcome to the pulmonary edema presentation. So one of the big classic things with pulmonary edema, and they stress it on the board exams as well, is a presentation with frothy sputum. So they'll cough up this like white or pink froth sputum, and it's going to be one of the classic signs and symptoms that you'll see with pulmonary edema, whether it's cardiogenic or non-cardiogenic, which means is it the heart failing that's causing blood to back up in the lungs, or is it something else that's causing fluid to back up in the lungs? So whatever the cause, whether it's the heart failing or something else, that sputum that these patients usually will have is that frothy white or sometimes pink sputum, and then we'll get into that. But that's one of the key things to get from this, and that's why I put this cover photo here of that froth on the coffee. So have fun looking at frothy coffee from now on, especially after you've seen a couple of pulmonary edema patients. But that's one of the things, one of the key clues that will clue you into what's going on with the patient on a board exam as well as in real life here and there. All right, so my book, chapter 20 is where the pulmonary edema chapter is. Pulmonary edema is the result of a lot of fluid from the pulmonary vascular system. So, and then it goes into the respiratory zone. So this is something, and I have a diagram in here that talks about the respiratory zone and how it really gets in there. But really, you're looking at a high pulmonary vascular pressure or a high amount of fluid in the pulmonary vascular system that then exceeds the pressure that's in the interstitium and the alveoli, and then it will leak into the alveoli, causing that edema, that fluid just to seep in there. So it seeps into the perivascular space and peribronchial and interstitial spaces. So you'll see that people with pulmonary edema, things that can cause pulmonary edema may also cause a pleural effusion as well. Things like congestive heart failure. If someone has congestive heart failure, they have blood that's not being pumped out of their left ventricle very well because the left ventricle is not good at pumping. So there's blood that backs up in their lungs, right? Well, that blood causes a lot of pressure, then it will leak into the interstitial spaces and all that other stuff, and it will also leak into the pleural space as well and cause a pleural effusion on top of pulmonary edema. So now you got both things going on. So just be very careful. There are things that can cause both at the same time, and that's why I love talking about pulmonary edema and pleural effusions pretty close together, or teaching them pretty close together, because in real life, if you have a patient with significant heart failure, congestive heart failure, they might come in with cardiogenic pulmonary edema and a pleural effusion at the same time that needs to be addressed. So both of those together will cause a significant decline in pulmonary function, right? They'll have a hard time getting oxygen to their bloodstream. Their blood pressures will not be stable. The heart rate will be very unstable, right? So you're going to have a lot of issues with these patients being stable. And when you talk about cardiogenic disease processes, it really throws a lot of pulmonary issues into prospect here. So the thing here is it starts in the interstitial spaces and it will move into the respiratory zone, the bronchioles, the bronchi, when it gets severe. So it will just keep on progressing. It gets pretty bad. In a lot of these patients, it goes into these spaces and it actually can cause wheezing too. Now, this wheeze will not be fixed by bronchospasm unless they have a bronchospasm component. Now remember, it can happen where you could have a bronchospasm component to almost anything that insults the lungs, right? Anything, whether it's fluid or histamine response, right? It could cause a bronchospasm response. So the other thing here is if you give a bronchodilator and there's no change in breath sounds, right, you still hear that wheezing, and sometimes it's audible. You could hear it from the doorway of the room. They might need more than just a bronchodilator. They might need something like positive pressure. So that's when we get into that therapeutic part later on. All right, so this is the picture from your book. It talks about that frothy white secretions, right, that's looking in your alveoli, right, that frothy white secretions. The interstitial edema that can lead into pleural effusions, right? And then you even have little red blood cells that will leak into the respiratory zone. And that's what can cause that alteration of that frothy pink, right, is the red blood cells would cause that pink tinge, sort of like we're washing a red sock with white load, right, when you're doing laundry. So that's something that you're looking at, is that pink tinge could be there because some red blood cells have joined the rest of that white froth, and therefore, you have a pink froth going on. Isn't that good? All right. Obviously, with all this going on, what do you think happens with your surfactant that's hanging out in your respiratory zone? Does it get diluted, or is it just staying stable and working just as well? It gets diluted, right? So one of the anatomic alterations is going to be atelectasis that happens with this. So after this patient is done with their cardiogenic pulmonary edema or non-cardiogenic pulmonary edema, you're going to have to deal with these patients getting their lungs to re-expand again. And that's a very common thing that's going to happen, is they'll have very low lung volumes. They'll have that atelectasis that resides. And so you're going to have to figure out therapeutically what to do with this specific patient that's going to help them re-expand their lung tissue most effectively. All right, so let's talk specifically about anatomical alterations. This fluid movements will move into the interstitial spaces as well. I have that slide coming up for you guys to look at that. That swelling will intensify, and then as the surface tension of the alveoli increases, this will cause the alveoli to shrink, right? This is because all that fluid's getting diluted, your surfactant's getting diluted. The tracheobronchial tree will have a lot of frothy white, sometimes blood tinge, which is the pink, right? That red blood cell causes that to be pink, to come up. So this patient might be coughing. Usually it's this like sort of dry hacking cough initially, and those are the J receptors in the respiratory zone getting stimulated. Then you later on you'll start to see that frothy sputum coming up out of there. Too much of this fluid in the interstitial space causes the lymphatic vessels to widen, and then the lymph flow will increase. Remember, you have less lymph on your right side than your left side, so that's when you mostly have a chance of getting a right-sided pleural effusion with this as well, right? Because remember, the lymphatic vessels get overloaded in this case, right? So when we're looking at this, we have alveolar flooding, so a bunch of fluid just filling up into the alveoli, increased surface tension of alveolar fluids. That means surface tension is a bad thing, right? Remember, that's the ability for water molecules to stick together. That means atelectasis. Now it's going to be filled with fluid and collapsed. Isn't that great combination? No, it's a terrible combination, right? So it goes from being filled with fluid, that surface tension increases because we're diluting surfactant, and now we go to atelectasis, right? So we have alveolar shrinkage, atelectasis, and then we have that frothy pink or frothy white secretions. Every time I've taken the board exam, they always talk about it as frothy pink, but those are key words that you should pay attention to. Pink or froth. Froth, I guess, would be sort of the key word in this whole situation. Every time you see that, just in general, start with thinking of pulmonary edema, and then what treatments and things you would do for that. All right, so this is not in your book, so this is just looking at the histological slides. I like looking at histology. And so this is what you're looking at, the distended capillaries down here. You see that bottom right picture where it's showing you the distended capillaries. And that's because there's so much pressure built up there. So there's a higher pressure in the pulmonary capillary than there is in the alveoli. So that fluid will seep into the alveoli. It's pretty crazy. I love these pictures, but just seeping into the alveoli. I wish there was a good animation out there. It's just seep into there, and then you're going to see the microhemorrhages that will show up on their histology, but that's where you develop. See all this frothy pink in the top over here? See all those little pink little dots that are in this area, that are in this alveoli? That collects together to form that frothy pink sputum that they'll cough up. So I love these slides. Hopefully they help give you a better visualization of how the capillaries get overloaded and leak out, and then it will cause up here what you see in this upper left picture is that little dots, right, to leak in there, and that's that red blood cell. Right, so this is another one. This also is not in your book too, but this is looking at the lungs from the outside perspective. And I just hopefully try to get you guys a better mental picture of this, because I believe strongly, I'm a visual person. I love thinking about these visually. I mean, one day I'll make this sort of really fancy computer model that'll have all the diseases in there that you could 3D picture, touch, 4D, play with in real time too. But until I can figure that out, you're just going to have to deal with my weird pictures. But this is looking at the outside of the lung tissue. So look at the outside of the tissue, and you can see how much pulmonary edema is present here. You can see the excess fluid within the lymphatics. That's just causing that edema just to seep out and hemorrhage. It's pretty crazy just to sort of see that just sort of weeping and seeping of fluid and how much excess fluid is going on with this patient. So you can just sort of see it's just all this pressure just pushing that fluid out, whether it's from heart failure or another cause. Right, this is that really boring slide I was talking about earlier, but this is sort of a good picture. I like this one looking at the interstitial. So obviously you have your capillary, your interstitium, and your alveoli, and you have your blood moving through here, right, through the capillary, right. I'll make this deoxygenated purple blood, and then we can hopefully go to red, arterial oxygenated blood. Okay, so this is all flowing through here, right? This is your AC membrane. Hopefully you're getting oxygen in and CO2 out, right? That's the whole plan, right? We're going over here on that left side. So this is the normal plan of things over here, right? So when we're looking at this is an interstitial space that's sort of in between around the alveoli that doesn't have the AC membrane. So that interstitial space is sort of there. And remember, this has mostly lymph tissue. So if there's a lot of fluid that's building up here, then we're going to have a larger interstitial space that will then leak fluid into the pleural space as well. So it's pretty crazy stuff when you're looking at it. If this slide doesn't make sense, that's okay. This is sort of meant just a different way to look at it visually as far as a graph goes. Like I said, it's okay if you don't get this slide, but it's looking at that third space or that loose space. Because remember, in pulmonary A&P, we talked about the tight space being the communication between the alveoli and capillary. Well, this would be the tight space that I'm highlighting here. And then the loose space, I'll just use blue here. The loose space would be these areas over here that don't have capillary contact with it, and it's mostly lymph tissue. So that's what we're looking at here. Is all this other stuff. That lymph area gets overloaded with fluid because there's an excess pressure here of blood, right? So let's go to purple blood. So we have purple blood in very, very high pressure. Very, very high pressure. And there's so much pressure, some of it's not going across the membrane, or instead of just gas going across the alveolar capillary membrane, some of this fluid will start to seep out into that interstitial space. And I hope this sort of is starting to make sense. There's just so much pressure. The capillary pressure is so high that it cannot hold that much pressure, and it just leaks that fluid out into that interstitial or that third space. And usually that's your pleural and your lymphatics that overload. All right, so there's two general types. So cardiogenic pulmonary edema is usually as a result of cardiac failure, right? So this is left-sided heart failure, which is congestive heart failure, right? Left-sided heart failure is where that left ventricle is just not able to pump, and it's usually been dilated and it can't contract very well. So it's a very weak pump. So there's something here where you're looking at the left ventricle function. And this LVEF is not a typo. It's left ventricular ejection fraction. So sometimes they'll just call it ejection fraction, right? So if you guys are working in a cardiac ICU, you're working in an emergency room, if you're plan on working in critical care medicine, this is going to be a term you need to know, especially if you work in cardiac ICUs, right? And cardiac ICUs need good quality respiratory therapists. So left ventricular ejection fraction or ejection fraction, less than 40% may confirm heart failure. Less than 35% is life-threatening. In other words, that's not maintainable, right? They're only pumping out 35% of what they should be, right? And a lot of times in this situation, that left ventricle, even though it's a weak squeeze, is working really, really hard and requiring lots of oxygen. And this is where you might see cardiac arrhythmias originate as well. So big issues here. Not only will you see heart issues, right, with arrhythmias being present and low perfusion to their organs like their lungs, their brain, their kidneys, but yeah, you're also going to see the heart start to go into an arrhythmia as well. So blood pressure usually is going to be pretty low. And then when it goes into the alveoli, it will form what's known as a transudate. Transudate and exudate, we'll go into that in the pleural effusion presentation, but a transudate is very low in protein, very thin, very translucent, very white, very see-through, low in protein content. Right? And when we're looking at this is because the hydrostatic pressure, or the pressure inside, moves the fluid from inside the vessel. Right? We talked about that in that last screen. There's so much pressure inside the vessel, it just keeps building and building and building until some of it leaks through. It can no longer be contained by the capillary, and that's what you're seeing. Normally it's offset by the osmotic forces that tend to keep it in the capillaries, but now it's exceeded that osmotic pressure. It can no longer keep it back, and so there you go. There's a break, and that's causing that fluid to seep out of that capillary, and it's just the oncotic pressure is just not there anymore. So this is, you just have the heart failing. So here's the right side of the heart, I'll draw it in purple. The left side of the heart, I'll draw it in red, because it's supposed to be oxygenated blood. So we have the pulmonary veins. Remember that empty into the left side of the heart. Pulmonary artery. Oh heavens. Pulmonary artery on the right side of the heart. So obviously we're going to have a backup in right-sided heart pressures because there's so much stuff in here. Left-sided heart, the left side of the heart's not squeezing very well, it's sick. And so left ventricular output that we talked about, ejection fraction, is going to be very, very low. A normal ejection fraction should be greater than 60%. So you should get rid of most of that blood after every squeeze. Well, what's going to happen if we're not squeezing blood out to the aorta very easily, right? A lot of it's going to stay behind and start to build up and go back through those pulmonary veins and back pressure into the pulmonary capillaries, right? And that's when we're going to get excess pressure build up. So not only will your left-sided heart pressure, your cardiac output decrease, and we'll talk about that in the hemodynamic section, but you'll also see all your right-sided heart pressures increase. So ultimately, I know I drew a lot here, but here's the bullet point. Here's the take-home thing from this. With cardiogenic pulmonary edema, the left ventricle is sick. It is not working very well. And because it's not squeezing very well, blood will back up in the lungs. That fluid will then start to seep out of the pulmonary capillaries and into the pleural space and into the alveoli. That's what you're looking at here. One of the key things, too, that I want you to pull from these slides is on the second to last one. It talks about albumin. Albumin in critical care medicine is used when people have a lot of edema. Albumin can actually help increase blood pressure because it'll pull it from the third spaces, increase your oncotic or osmotic pressure, and therefore pull fluid back into your blood vessels and increase your blood pressure again. So it's actually used as a volume expander. It's used as a medicine, even though it's something that your body naturally has. It's used as a therapy for hypotension. So if someone's blood pressure is super low and they have a lot of like edema around their ankles, their wrists, their fingers, right? They can actually give them albumin, and that might help increase their blood pressure, because then we'll have more fluid going into their veins, their vessels. It's pretty cool. So hopefully you got that big bullet point. So ejection fraction, if you're working critical care medicine, this is going to be something that you're going to be paying attention to as a critical care provider. You need to look at what their ejection fraction is. Now, for the purposes of this course, do I want you to have this memorized? No, but if you have this memorized, if this is something that you just put in your notes and you just review, you will not regret it, especially if you work in a cardiac ICU down the road. Oh, heavens. I don't want you to get freaked out by this slide at all. There is only one thing I want you to get from this, and this is looking at the Starling equation. And hopefully you covered this a little bit in cardiac, in your cardiac classes. And so this is just balancing hydrostatic and oncotic pressures. Okay, so this is this whole equation. But here's where I want you to see. I want you to look at this bottom left-hand area, okay? It's saying that the pressure in the blood vessel, so BV, versus the interstitium, which is that area that's sort of around the outside, right? That loose space. Remember we talked about loose space and tight space. It's that loose space. So if the pressure in the blood vessel versus the interstitium is larger, it will larger proximally, right? Not distally, but proximally. It will favor fluid entering into the airspace. In other words, it's saying the higher the pressure, the more likely fluid is to seep out into this third space area. And that's all I wanted you to get from here, right? There's this whole equation. It makes you look super smart if you can just write this on random things, leave it on notes around the place, be like, hey, guess what I learned today, right? But that's the Starling equation. This is something, you know, I've only seen cardiologists talk about. But this is the take-home point. When you're looking at oncotic pressure and hydrostatic gradient, oncotic pressure over here is looking at the reabsorption of the fluid back into the blood vessel. So that's the fluid re-entering back into the blood vessel from the interstitium. That protein in the blood draws oncotic pressure. So if we give this patient over here albumin, right, because they got all this free-floating fluid in this interstitium. If we give them albumin, it's actually going to increase oncotic pressure, and that will suck the fluid into the blood vessel, and therefore not only increase blood pressure, but also reduce that free fluid. Pretty cool, right? Like I said, don't stress about this whole equation. I'm not saying it's not important, but I just want you to sort of look at oncotic versus hydrostatic, and we're just comparing blood pressure inside the vessel to the interstitium, and if there's more pressure in the blood vessel, then it's going to leak out. And if there's less blood pressure in the vessel, if we increase the ability for that vessel to stay closed, it'll actually suck some of that edema back into it. It's pretty cool. All right, so we talked about cardiogenic. Now this is non-cardiogenics, all right? So pulmonary edema is based in two general categories, caused by the heart or caused by something else. And so we just talked about caused by the heart. And so this is the caused by something else category. So non-cardiogenic pulmonary edema. Usually this can be a result of infection or inflammation. Right? We did talk about this a little bit with, I think it was asthma, where we can get a little bit of pulmonary edema too. That inflammation is sort of that key part there. So anything that causes a massive amount of inflammation can easily lead into non-cardiogenic pulmonary edema. Obviously, with all this stuff going on, alveolar hypoxia can easily cause this as well. What happens to the blood vessels when they're hypoxic in the pulmonary capillaries? Well, they vasoconstrict, right? And so what happens to the pressure inside of a vessel if it gets smaller? So I got pressure and volume. If the volume of the blood vessel decreases, So if the volume decreases, that means the pressure inside the vessel will increase. It looks like a gas law, but using fluids. So if the pressure inside the vessel increases beyond the pressure that the vessel can contain, what will happen to that fluid? It'll start to weep out. Hopefully this makes sense to you, right? That's what we're looking at here. If that alveolar hypoxia, if we don't have enough oxygen to keep those vessels dilated, the blood vessels will shrink. That increases pressure, therefore increases the chance of pleural effusion, pulmonary edema. Something called ARDS, we'll get into that in a presentation down the road. Inhalation of toxic agents, like we had with the chlorine gas inhalation, with different things like that, that can easily cause that free-floating edema and fluids in there. Infections, of course, can easily do it. Therapeutic radiation, so lung cancer patients undergoing radiation therapy can easily go into pulmonary edema as well. Acute head injury, we'll talk about that more in relation to critical care medicine when you guys get to emergency care. Lymphatic insufficiency, especially if someone has had a lymph tissue removed, like a mastectomy, and they've had lymph tissue removed, things like that. Low pleural pressure. This can usually be as a secondary result of a pleural effusion that we just got relieved. So we'll talk about this in the pleural effusion presentation, so go look at that one. But when you have a massive, let's say it's a 2-3 liter pleural effusion, so the lungs being crushed, and we go in and we pull it all out at once. We put a needle in there and we suck all 2-3 liters out all at once. Well, the lung tissue is going to re-expand because it's not getting crushed by fluid anymore. So when that happens, that re-expansion, so here is your lung, and then here's all this fluid hanging around your lung. And then down here, we have your chest wall, and then now your lung has re-expanded, right? So what happened is your lung re-expanded because we removed all this fluid that was just sort of hanging out in there, right? We removed all this fluid that was hanging out in there. So when we did that, the lung re-expanded. Well, when the lung re-expanded, it created negative alveolar pressure. So there was less pressure in the alveoli than there was in the blood vessels. So we created a vacuum when we re-expanded everything. So that means there was a pressure gradient from the blood vessel into the alveoli. So that's called re-expansion, pulmonary edema. So that's after we rapidly drain a massive pleural effusion, then we re-expand that lung tissue, then it can easily cause that pulmonary edema component to it. And so we'll talk about that in the other presentation, but you should be aware of re-expansion. Pulmonary edema can easily happen. Even can happen with the pneumothorax as well. So something to look at there. So noncardiogenic causes, there's a lot of them. Allergic reactions can easily cause them. Overdosing, metal poisonings, alcohol ingestion that's chronic, not just before a test. Aspiration, of course, can easily cause this. This is one of the things, especially aspiration. Pneumonitis can lead to what's known as ARDS, which is a syndrome, and that's going to be a separate presentation we'll talk about. Aspiration, ARDS, is very, very serious, and one of the big things that goes along with ARDS is pulmonary edema that you'll see here. Encephalitis, right, that brain swelling, so acute head injuries, closed head injuries, all those can be very dangerous to the lungs as well. Something called high altitude pulmonary edema, especially if you're going to work here at altitude, that's going to be something you need to be aware of. Hey, what's this? A pulmonary embolism, right? We talked about that with the pressure. Here's your blood vessel. Here's the clot, and then all the blood behind that clot builds up, builds up, builds up, builds up, builds up. It keeps increasing pressure until, right, it'll leak out. So that's what you're looking at there. Eclampsia is when someone, usually they're still pregnant, has super high blood pressure and they go into a seizure state. It's a very, very bad situation there. We'll talk about that in perinatology. We talk about preeclampsia or pregnancy-induced hypertension, and then preeclampsia and eclampsia. If you work critical care medicine or at a place, I would be aware of what eclampsia is and all that stuff that goes with it. But that's not something we have time for in this class, unfortunately. And then finally, one of my classic ones is a transfusion-related lung injury or trolley. This can easily happen. I had a patient that had they had cold blood that was given to them. The care team did not warm up the blood before they gave it to this patient. And the patient started having shortness of breath, their saturation started dropping, they started working hard to breathe, like you can see their accessory muscles. So they called me to come to the room. I was the respiratory therapist covering that area of the hospital. I came to the room and I asked about their vital signs, and I was looking at what was hanging right on the IV pole, and there was blood hanging on the IV pole. So I'm thinking, were they anemic, right? Was it an anemic hypoxia? Remember HAC? Histotoxic, anemic, circulatory, and hypoxic hypoxias. Hopefully you remember the HAC. So when we were looking at this, I was like, oh, maybe they were anemic, and then, we just need to wait for the blood to do it. And then I touched the outside. So obviously I didn't touch, like, the actual blood going in there. I just sort of went over to the IV pole and touched the blood. The blood was super cold, and their blood pressure was fine. The patient's blood pressure was fine, so it wasn't circulatory hypoxemia, wasn't anemic. It wasn't histotoxic. They weren't poisoning her. Hypoxic hypoxia was the case here. And so her issue was they gave cold blood. And what happens with things when they're cold, like with ice cubes, your capillaries through your lungs are only thick enough, or so thin, I should say, that only one red blood cell at a time can sort of float through there. So if you make the red blood cell cold or freeze it or get cold enough, the red blood cell will get bigger. So when this happens, when the red blood cell gets bigger, what do you think happens to the capillary? Does it keep its integrity, or does it cause trauma to the capillary and cause ripping and tearing? Well, that's what we had here, is the cold blood was actually ripping and tearing and the pulmonary capillary and causing pulmonary edema. She was a case of pulmonary edema. With this individual, I put her on a little bit of CPAP because she was working hard to breathe. Her saturation wasn't good because she had histotoxic hypoxia. Hypoxic hypoxia. Messed up there a little bit. Hypoxic hypoxia because they gave her a transfusion with cold blood. They didn't have it warmed up enough. And then so she got a transfusion-related lung injury there, Trally going on. But transfusion-related acute lung injury should be a Trally, not when we're looking at this. So just different things just to be aware of. I had another patient who was a non-cardiogenic pulmonary edema situation. So yes, I'm boring you guys with stories. I had a patient, I was called into the cardiac step-down ICU. Patient was wheezing like crazy, wheezing, working hard to breathe. The nurse told me they had transferred this patient from a different floor where they had just given her some nebulizers, and she wasn't looking good, so that's why they transferred her to the unit I was in that day. And so I go in there, and she's wheezing from the door. I didn't even need my stethoscope to hear her wheezing. Right from the doorway, I could see her working hard to breathe and wheezing, and the nurse asked about another bronchodilator, and I knew that she had just had one, and obviously it didn't show relief of her symptoms, so that spiked me to question She's working hard to breathe, so why don't I put her on some sort of positive pressure that's going to help relieve how much her body has to work to breathe, right? I'm going to help relieve, I'm going to be therapeutic until we can figure out what's going on. And so I worked on giving her some positive pressure. I just gave her some CPAP. And her wheezing went away, her work of breathing went away, her heart rate started dropping, which was good, right? It wasn't a bradycardia. Her heart rate started dropping because we were taking the workload off of her heart, and we were being therapeutic with her. And the doctor showed up, and he's like, yeah, she's in pulmonary edema. And he's like, I'm so glad you didn't suggest diuretics. And I'm like, oh, no, I wouldn't suggest diuretics because I looked at her labs. And she was in kidney failure as well. And so to give diuretics, you're going to pull fluid off their blood vessels. And if their kidneys aren't working very well, and that's how diuretics work, they work in the kidneys, you're not going to be very therapeutic, and you could actually cause harm in this situation and cause them to go into a metabolic acidosis. So all that to say is, like, looking at someone that is in pulmonary edema, whether it's cardiogenic or non-cardiogenic, look at them. How severe are they? What therapies are going on in my brain? And then we can start working on a treatment or a cause, a treatment for the cause, right? And with her, her kidneys were failing, and that's why she was building up excess fluid in her body, and then that included her lungs. And so I needed to support her with positive alveolar pressure, right? Because if I increase alveolar pressure, right, even though there's fluid that can still seep out into that loose space, into that pleural space, there's still fluid that could seep out. I'm providing so much positive alveolar pressure, right, P big AO2. I'm providing more positive alveolar pressure than there is pressure leaving the blood vessel, so that reduces the amount of blood or fluid flowing into the alveoli. So that's why I used that positive pressure. And for her, it was therapeutic. And some of those patients might need more CPAP than just 5. I used a CPAP of 5, and she started showing therapeutic differences there. So I did not go further than that. But little things like that can make the biggest difference between her ending up on life support or her just needing CPAP for a little bit until her kidneys catch up. Right? So that's a whole separate bunny trail, but still related to what we're talking about. Risk factors for pulmonary edema: obviously cigarette smokers, obesity, people with high blood pressure and high cholesterol, diabetes, both type 1 and type 2, sleep apnea, big component that could happen there, congenital heart defects. These are obviously more common if you work in the pediatric side of things. Pulmonary embolisms, right? Be very aware, pulmonary embolism patients are prone to pulmonary edema as well. Right, so if you see that pulmonary embolism patient, they might also go into pulmonary edema. Then you have both things going on simultaneously that can complicate saturations and work of breathing. Obviously, renal failure, right? That's the case that I was just talking to you about earlier, right? That patient, she was in renal failure, and that's one of the reasons why she built up so much fluid and had that non-cardiogenic pulmonary edema. And obviously cardiogenic risk factors as well, especially with left ventricular failure there. All right, so what will this patient look like? And we've already actually talked a lot about this screen. All right, so a lot of this they'll have, by the time they get to the hospital, or significant enough that you'll see it, they'll usually have an atelectasis and increased AC thickness. So if you, in theory, did a DLCO with this patient, right, the DLCO would be decreased. If you did one. Now, these patients are tachypnic, tachycardic, they're high blood pressures, they're orthopnic, right? They're cyanotic. Do you think you're going to get someone that looks this severe to go do a PFT for you? Right? So not likely. So I'm just saying, in theory, if you did a DLCO, it would be low, right? That's just for your brain to sort of look at the pathophysiology of what happens to the AC membrane. Well, the AC membrane gets thick because it's full of a bunch of fluid and stuff like that, right? Lots of secretions, right? And we're talking about that frothy secretions, right? The key word is froth. So what will they look like? You put your Pima scrubs on, your Pima stethoscope, you're in the ER. If someone shows up with pulmonary edema, they'll be breathing fast, right? They'll have a fast heart rate because, remember, your cardiac output is stroke volume times heart rates. And if you're not squeezing out blood very easily, to compensate to get to a normal cardiac output, your heart rate's got to increase, right? And so you'll see that tachycardia that's going on with that. Hypertension, of course, they have that backup of fluid. Shane-Stokes pattern of breathing, we talked about this in pulmonary A&P. This is where they have, this one was the Bob Ross one, right? Where they have apnea, and then they have gradual increase, 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 and then decrease, 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 and then apnea again, right? So that's what you're looking at there, is that Shane-Stokes pattern of breathing, right? The mountain range, if you will. Orthopnea, that difficulty breathing while lying down. This is sort of a key phrase that we haven't talked about in the other conditions yet. This is one of the classic things. You put this person to lie flat for a CT scan, right, like a chest CT scan or something like that. They're going to have a very, very difficult time breathing doing that. A lot of these heart failure patients will actually sit sleeping up in their lazy boy. They'll sit up to sleep. They'll have that propping of all their pillows and stuff like that. Of course, cyanosis, they'll have that cough. Remember that frothy pink or white appearance, and the pink one's the one that you usually see on the board exams. Fremitus, because there's density, increased fremitus, crackles, and wheezing present with this one as well, right? Anything that's in the airways, whether it's frothy sputum or secretions, right? Anything that makes an airway narrower, whether it's inflammation, bronchospasm, mucus plug, toy car, whatever it is, can cause a wheeze, right? It's just that narrowing, and no matter what the cause is, and that's what you're hearing there, is that frothy secretions causing that as well. Oh, the crackles that you hear usually are inspiratory and expiratory. Inspiratory, late inspiratory is usually atelectatic, right? Remember the atelectasis is one of the things that goes along with this. And then expiratory, throughout the respiratory cycle, usually you'll hear this, is that just that fluid, and it's those fine crackles, that popping sound, not the ronkerous, like the vibration sound, but that popping, that crackling sound that you usually hear there. Like the Rice Krispie treats, right? Or Rice Krispies, I should say, the cereal that would make. On X-ray, in non-cardiogenic pulmonary edema, usually you're going to see the most of the density happen at the hilar area, so the H part. If you do the A through I technique that I use in the chest X-ray evaluation slide presentation, that's where I talk about looking at the hilar. That's what you usually see in non-cardiogenic pulmonary edema. Pleural effusions, usually not present in these patients. One of the ways that we can tell if it's cardiogenic or non-cardiogenic is actually looking at the silhouette of the cardiac part of it. So when we do the C technique, if we see that the heart is taking up half of the chest space, then we know that it's looking at probably cardiogenic pulmonary edema. If the cardiac silhouette is only taking up a third of the thoracic space, it's probably not cardiogenic in nature, right? It's probably a non-cardiogenic, and that's what you're looking at here. The cardiac silhouette is normal in non-cardiogenic, right? Because remember, the problem is not the heart in this one, it's something else causing it. Now in cardiogenic, this is where you're going to probably see that cardiomegaly on the x-ray. So this is where you see the heart being enlarged in the cardiogenic. On cardiogenic, usually you'll see dilated pulmonary arteries, because that usually implies a long-term backup of right-sided heart pressure, right? Left ventricular hypertrophy, we already talked about this one. Curly A and B lines, I'll point those out to you here. Bat wing or butterfly pattern, I'll hopefully point those out to you. And like I talked about earlier, pleural effusions are especially common in your heart failure. You also see pleural effusions more common in your lung cancer patients as well. And I think we already talked about that with the lung cancer. Okay, so this is a picture from your book. So what do you think about the heart here? If you're doing the A through I technique and you get like aphyses, okay, I don't see any coin lesions, B's, bases, I have a good CP angle. Yeah, both of these CP angles are actually really good, right? I have good arches. McDonald's would be proud of those arches. So when we're looking at that, C is the cardiac silhouette. Do you not see how huge that heart looks on this x-ray? So this looks like a cardiogenic pulmonary edema, right? It's greater than half of the diameter of the thorax when you're looking at this. This is taking up way more than half of the thorax. So it's a big sign that it could be, it's probably cardiogenic pulmonary edema. And then you can see all the fluffy infiltrates that are surrounding this. Even in the hilar area, it's pretty bad backup of fluid in there. They would call that vascular congestion is the fancy word for that. Okay, so this is another picture from your book, but it actually shows it pretty well. These are curly A and curly B lines. Curly A lines radiate from the hilum, from the area in the middle, right? So this is the curly A lines because this is like, here, let me draw over it. I'll draw over the one underneath it. Right, do you guys see what I'm doing? Right, so you see it's like that first stroke of the letter A. Right, that's a curly A line, right? So hopefully that's helping to highlight it for you. That's a curly A line. That's vascular congestion, right? That's the increase in pressure or fluid in there, and that's what's showing up. Curly B lines are the ones on the peripheral. Those are the ones on the closer to the external part of the chest cavity. So here's the B lines, right? And so this is where you're looking at. Hopefully this helps you a little bit. I'm a visual person, so I love this type of stuff. Right, so you have your curly A lines and your curly B lines, and I hope this helps somewhat. Here's another one. It's kind of fun. So when you're looking at these, you have to usually zoom in when you're looking at the chest x-rays. Most of them are computerized nowadays, so it's pretty easy to zoom in. And you can zoom in, and if you start to see curly A's and curly B's, that's a definite sign that pulmonary edema is a component to what is going on with the patient. So curly A's are in the middle, curly B's are outside. Oh heavens, so what are you looking at this one? Do you see heart failure? So you think this is cardiogenic or non-cardiogenic? Just looking at it, right? Just looking at this. I would lean towards the cardiogenic on this one, but this is the bat wing or butterfly pattern, so whichever one you want to use, whichever one floats your boat there, go for it. So this is bilateral. It's not it's not even on both sides. It's not symmetrical, and that's normal. It's normal to have it sort of show up in that right upper lobe first, or you'll hear it more common in the right lung first, because remember, you have less lymph tissue. Where? Your right or your left lung? In your right side. So if I have less lymph tissue on my right lung, where do you think most of this stuff is going to show up? Right? So most of it will usually show up in that right lung first, and that's what we're looking at here. So that's why you may not see it very symmetrical between when it shows up. So you might see it worse on that right side. So this is bilateral, not symmetrical, but bilateral, and you see a lot of parahilar portions, and this is where you're looking at the butterfly or bat wing pattern. And so what color? Let's do yellow. I can pick yellow. There we go. Butterfly. And then you sort of see it over here. Not as prominent, but there's your little butterfly. I should not, yeah, I'm glad I didn't go to art school. And when we're looking at this, there's that bat wing or butterfly pattern. Obviously, my brain went to butterfly, but I don't know what that reveals about me or not. But there you go. As long as you remember that is a sign of pulmonary edema, then you're well on your way looking at this. in an appropriate therapeutic manner, because then you're like, okay, pulmonary edema, hey, what's the cause? Left ventricular failure. Okay, let's work on a positive inotrope for the patient's heart, or fluids, getting rid of fluids. But in the meantime, what can we do to help their lungs, right? So understanding and recognizing these x-rays will help you better, not only therapeutically, but diagnostically. It'll help you better at the bedside be like, okay, this is what's going on. Let's do this for now until we figure out exactly what our game plan is to treat the cause. Okay, another picture. So I put this in here. This one I don't believe is in your book, right? So I put this in here on purpose because you don't have access to it. This is a 60-year-old male that had a right mid and lower pleural effusion. So, this is pleural effusion, right? And so you can see on the picture on the left, and I still have the yellow on here, see that highlight mark and see how much lung we have hardly any lung going on there. So the rest of this, right, this is his left lung. The rest of this is just filled with fluid, right? So here's the situation. Massive pleural effusion. This is over 2 liters that they drained with a pleural tap. So they put a needle in there and they drained most of this fluid that's on this patient's right side, okay? You're like, well, that's pleural effusion. Why are you talking about this in the pulmonary edema category? So look at the picture on the right now. So you see they got rid of most of that fluid. The CP angle has returned. Yay, right? That's a pretty decent CP angle that we got there, right? Pretty symmetrical over there, all right? So that's good, but hey, what's all this about? You see all this haziness? Well, this is re-expansion pulmonary edema, right? Remember I talked about the lung was crushed, and when we restored that lung tissue, the alveoli got re-stretched back out, it created a bunch of negative alveolar pressure. That means that we created a vacuum to suck fluid into, right, that space. And so that's what you're looking at, is that re-expansion. Pulmonary edema. So this is an uncommon complication. In other words, it doesn't happen every time they drain fluid out of the pleural space. It's just something for you guys to be aware of. And this can happen, like I said, you resolve the pneumothorax that has a massive pneumothorax on that side. You can also have re-expansion pulmonary edema from a pneumothorax, not just a pleural effusion. But remember, we're looking at that negative pressure that we created in that respiratory zone and in that pleural space that created that suction that pulls fluid into their area. So that's what that re-expansion pulmonary edema is all about. And so usually when we go to aspirate, or not we, but when whoever goes to aspirate that, usually interventional radiologist, that fluid, they usually don't take off any more than about 3 liters at a time. So let's say someone had a 4-liter pleural effusion. That actually happened a couple times on me. Someone would have a 4-liter, would go down to IR, and they would only take off 2 liters or 3 liters, and I'd ask them why, and they're like, oh, re-expansion pulmonary edema. Not something I ever recalled learning about in school, but now, hey, guess what? You guys have that. And hopefully you'll be able to recall it. I hope so. That would be cool. Another slide that's not in your book. I love these things. So this is also looking at a meniscus sign over here of a pleural effusion. You can see how that's that meniscus, or that fluid that's sort of building up in there, what the arrows are pointing over. So the fluid was resolved from the left picture to the right picture. Now, can you not guess this patient had? See these? These are signs that their sternum's been propped open for a open heart surgery. So odds are, look at the heart too, right? Talk about cardiogenic pulmonary edema and pleural effusion here, right? You can see how pleural fluid built up not only caused a meniscus sign that didn't go all the way to the border, but also built up in the oblique fissure as well, right? In between their lungs. And so in the picture on your left versus the picture on the right, this actually shows re-expansion pulmonary edema as well. So that's just trying to get you along the lines of thinking, if you're in a case where you resolve a pneumothorax or you resolve a massive pleural effusion, I want your brain thinking, why is this patient still having trouble breathing? Could it be something like re-expansion pulmonary edema? That's the bullet point. Okay, so we're not talking about a patient that is short of breath, tachypnic, tachycardic, their blood pressure, right? We're not talking about doing a PFT on that poor looking patient, right? We're talking about this sort of when the patient is stable. What would their PFT be? So when we're looking at pulmonary edema, their volumes are going to be low. Their flow rates are going to be normal or low, sort of depending on what's going on. So when we're looking at this, we'll just make this in general that their flow rates are normal for now and their volumes are low when we're looking at this. So that sort of makes it a little bit easier. But definitely this is restricting the lungs from expanding. Remember, it's restricting the lungs from expanding. You're like, okay, what's the deal with the low flow rates? Well, the low flow rates is what happens to, if this is noncardiogenic pulmonary edema and we have massive amount of inflammation going on in the lungs. Is gas going to flow really easily through that narrowed tube? Absolutely not. So then it would show both decreased volumes and decrease flow rates, and that's what is trying to be representative there as well. So just in general, remember this is a restrictive process, and that's how we'll look at it. So it's restrictive to volumes, their flow rates would be normal. If I gave you the case that someone with an underlying COPD with an asthmatic component, also has congestive heart failure, which, believe it or not, common. I'm not making that up. It's actually very common. Heart failure, asthma, COPD, all three, right? Also with diabetes. But anyway, that patient starts having pulmonary edema. They'll have both low volumes and low flow rates, of course. All right, ABG, when we're looking at this, ABG in the mild stages, so this is the patient that's short of breath, working hard at breathing. What would their blood gas look like? We're trying to quantify how severe this patient is when they come into the emergency room or when we're seeing them on the floors. It would be a respiratory alkalosis to begin with, because remember the cyanosis causes an increase in respiratory rate, which would then cause a decrease in CO2, right? This is that pathway that we've seen with everything else so far, right? Severe, they'd be in the respiratory acidosis because their lungs are not able to compensate anymore. The CO2 now has built up, and oxygen can't get onto the red blood cell because CO2 is still hanging out there, and there you go. You're in an acute respiratory acidosis because both ventilatory failure and that darn CO2 molecule. All right, oxygenation. This is going to be a shunt-like process, so oxygen therapy, yes or no? Hopefully you said yes for that. DO2 is going to be decreased because CCO2 is decreased because CaO2 is decreased. And if CaO2 is decreased, then DO2 is decreased. That's everything we've talked about in the previous ones. Your oxygen consumptions or your metabolic rate, right? VO2 and A to V gradient. Normal unless you have some sort of massive infection going on. And then your extraction ratio is increased because the DO2 is decreased, and then your venous saturation is decreased because you have that higher O2 Isn't that fun? Hemodynamics. So remember, here's the key. Moderate to severe. Not mild cases of pulmonary edema, but moderate to severe cases. Yes? If I give you a scenario on this next exam, right, is this a severe case or is this a very mild case? Okay, I'll try to either make it severe or mild for you because moderate can be very cloudy if you're not in patient care. All right, so let's look at right-sided heart pressure, CVP, right atrial pressure, pulmonary artery pressure, pulmonary vascular resistance, right ventricular stroke work index. All of the right-sided heart pressures are increased. So a lot of stress and pressure on the right side. Left-sided heart pressures, pulmonary capillary wedge pressure is increased. That means that, especially in cardiogenic, that means the left ventricle is not doing well, right? When the pulmonary capillary wedge pressure is increased, that means the left ventricle is sick. Okay, so there's our broken cause. That's what's causing the issue on this patient. That's why their cardiac output is low. That's why their stroke volume is low. That's why their stroke volume index is low. That's why their cardiac index is low. That's why their left ventricular stroke work index is low. And their systemic vascular resistance is like their arteries back pressuring. So it's going to be high because it's going to have that backlog of fluid. So left-sided heart pressures are going to be low, except for the pulmonary capillary wedge pressure where the issue is. Right? That's showing that there's a backup of blood right there. This is telling us about the left ventricle specifically, right? The pulmonary capillary wedge pressure. And if that one's high and everything beyond it is low, that's where the car accident is. That's where the problem is, right? And so that's how we know this is a left ventricular problem. So this is more common in your cardiogenic pulmonary edema. All right, diagnosing pulmonary edema. They can look at labs. Their electrolytes are low, right? That can easily lead to pulmonary edema. BNP is a sign of left ventricle function, right? So this is looking at how well that left ventricle is pumping. And when we've done those case studies, hopefully you guys remember a little bit of those case studies that I used to do with you, a little bit here and there. That's something that I would put in some of those case studies, because this is one of the things that we would look at in the hospital to look at for heart failure. And usually levels above 300 usually indicate that there's some heart failure component to the situation. So that's the number that I would sort of look at there. So that's that 300 usually suggests heart failure is present. Something they probably won't talk about on the board exam yet, unless you're looking at the critical care specialist, acute critical care specialist, or sorry, adult critical care specialist credential. But this is something I would pay attention to in the hospital if you're working adult critical care, especially. BNP in the ER and in ICU is going to be very helpful, especially even if you're in step-down ICU. It's very helpful to know that their pulmonary edema is cardiogenic or non-cardiogenic, because that could also help you. If I want to do positive pressure and they have cardiogenic pulmonary edema, could positive pressure help or hurt? And we'll get into that later on, but not in this class. All right, therapeutic interventions. Your patients in pulmonary edema, what do you do, right? So it's based on the cause. This is non-cardiogenic or cardiogenic, right? What's going on with their blood pressure? Is it high or low, right? How severe is it? So non-cardiogenic, you're going to usually support ventilation. So if they're working hard to breathe, get them on a device that's going to help relieve their work of breathing. This could be non-invasive, right? This is like your CPAP and your BiPAPs. That's going to help relieve how much pressure their body has to use to breathe, right? So that's also going to, by doing that, that'll help oxygenate them as well. If it's cardiogenic, so non-cardiogenic, we're going to support their ventilation, figure out the cause, work the cause. Let's say it's electrolytes, right? Things like that, we're going to work the cause. If it's cardiogenic, obviously this is where we'll go into the circulatory support. Positive inotropes help the heart squeeze better. Negative tropes help the heart relax. So if someone has super severe hypertension, they could actually give a negative chronotropes to resolve hypertension. Pretty cool. Decrease heart rate. Chronotropes, negative chronotropes decrease. Chronos is time. So negative chronotropes decrease heart rate. It's supposed to be down arrow. Decrease heart rate. So if we decrease heart rate, we allow for more filling time for the left ventricle, and therefore might be able to improve it. Vasodilators, obviously if we vasodilate, will decrease systemic vascular resistance, which means there's less pressure for the left ventricle to push blood into the aorta, right? And that can actually help these patients. So vasodilators, antihypertensives, we already talked about this with the inotropes as well. Diuretics, hemodialysis and CRRT. So hemodialysis and CRRT, there is a difference between the two. When we're looking at hemodialysis, they're taking fluid off of the vascular system, and usually a somewhat rapid, and I'm talking a couple of hours as far as rapid goes, rapid manner. When we're looking at CRRT, continuous renal replacement therapy. This is doing it over a much longer period of time where we're taking fluid off their system. So this is an actual board exam question. If a patient is hypotensive, so their blood pressure is low, and we need to take fluid off of their system, which one would you recommend? Hemodialysis or continuous renal replacement therapy? Well, if their blood pressure is low, we don't want to take a lot of fluid off right away, because what will happen to their blood pressure? Their vascular volume will decrease and they'll lose their blood pressure. They'll become even more hypotensive. So this is where you would suggest CRRT. That's a board exam question. Not something I'm going to ask you right now, but I'm just helping you guys along. It'll make me feel better knowing that that's somewhere in the back of your brain for however long it is. Oxygenation, of course. Give them oxygen. This is a shunt-like process. It's going to help in the meantime. Usually positive pressure, whether it's non-invasive or invasive, can easily help support not only this patient's ventilation, but also hemodynamics as well. Because what's happening, especially if their heart is super big, so here, let me draw the lungs, right? If the heart is super big and it's dilated like we have a heart failure, now I'm going to ventilate this person and I'm going to give them a bunch of positive pressure. What will this positive pressure do to the cardiac notch? Will it close it down like a cast on a broken bone, or will it let the heart continue to expand fully? No, it's going to sort of encapsulate and close it and squish it, right? We're looking at squishing. In this case, remember, the heart's overstretched, and because it's overstretched, it can't squeeze very well. So it's like extend your arm palm faced up in front of you right now, right? All the way out, like lock out your elbow, right? Go and try to pick up like a pair of keys even with your arm fully extended, right? With your elbow locked out, right? Anything that's fully extended as far as the muscles go, you have to work a lot harder to curl that key closer to you. Now, if you're going to do the same thing, pick up like a cup or a key or some keys or something like that, and do it with your bent elbow, like a T-Rex arm, right? Still palm face up. You're going to have a lot easier time and faster time curling that object towards you because you have shorter movement to go. And so by actually putting these patients on positive pressure ventilation and restricting the expansion of their heart, we actually can help stabilize their hemodynamics and reduce end diastolic volume, which means we're reducing the amount of work the heart has to do with each contraction, which means we can actually help the heart recover hemodynamically with positive pressure ventilation. Isn't that awesome? I love this stuff. Airway clearance therapy is needed if they have a lot of secretions. Volume expansion therapy, especially after this person's over their acute stage, is going to be pretty helpful. If they're bronchoreactive, right, they're wheezing and they react to it, then yeah, go for it. But if they're not responding to it, then that's a whole separate thing. All right, review questions, and I think I have that for you. Common lung alterations that occur with pulmonary edema, go. All right, you are wearing your PEMA scrubs, you have your PEMA stethoscope, you're working in the emergency room next to a therapist. Someone comes in with pulmonary edema. What are some classic bedside things you'll see with them? Will they be hypertensive, hypotensive? Will they have a fast heart rate, slow heart rate? Will they be cyanotic or acyanotic? Will they have anything weird about their sputum? Will they be coughing? Will they, keep going? Will they have an increased fremitus? Will they have a decreased fremitus? Right, what's going on with them? What about their x-ray? What might you see? What are the classic terms that you might hear? What about their ABG if it was mild case of pulmonary edema? What if it was severe case of pulmonary edema? Oxygenation, what happens with their DO2? What happens with their consumption and metabolic rate? What happens with their O2-ER? PFT after the post-acute phase, what would happen with their volumes and flow rates? What if this patient had both an obstructive underlying disease like COPD, asthma, on top of having pulmonary edema, what would happen with their PFT? Would it be restrictive? Would it be obstructive? Would it be combined? Anything abnormal about their hemodynamics? You better have this one down. I'm just telling you now. Anything abnormal about their hemodynamics? What kinds are there again? What are the two primary categories that we're looking at? All right, this person has pulmonary edema. What interventions would you recommend, right? They're breathing this way. Their breath sounds like this. What would you recommend? What would help this patient in the meantime? Okay, so case study number 1. I put these in here. These are not in your book. And this is just sort of giving you a picture of what you could see if you work more in the critical care side of things. You have this person with a patient that shows up in the emergency department, shortness of breath, they're coughing, their temp's 101.6, heart rate's tachypnic, blood pressure is low. All right, the respiratory rate's 28, so that's fast, right? 82% on room air. That's a pretty low saturation. They're intubated, so they put an ET tube, and you can actually see the radiopaque line in here. They have dry mucous membranes. That's a unique sign there. Their mean arterial pressure is 46. Now, I'll tell you this now. We usually want a mean arterial pressure of at least 60. Now, how you calculate mean arterial pressure? Remember, it's your systolic plus diastolic times 2 over 3. And usually you want at least 60 for your MAP or greater, because we want perfusion to those vital organs. And I'll make you guys calculate this in critical care class and all that stuff. So not in this class, but usually you want a mean arterial pressure of at least 60. In this patient situation, the mean arterial pressure is 46. So very, very low perfusion to vital organs. Lactate is pretty high. It's not supposed to be that high. And uric means what? You tell me. That's a pretty important thing to know. So is this the patient in hydrostatic pulmonary edema or ARDS? Right? Risk factors, they're in septic shock. They have pneumonia going on, of course. Flooded lungs, dry exam. What do you think is going on with this patient? Right? And I'm not going to answer this for you. I want you guys to sort of go through this and look through this. Try to figure this out. And we will talk about ARDS more upcoming, especially if you plan to work critical care down the road. ARDS should be sort of a syndrome that you are very familiar with. All right, case study number 2. 45-year-old female with chest pain, shortness of breath. She has no fever. Her heart rate's 124. Respiratory rate's 32. That's pretty tachypnic. Blood pressure, holy cow. She is on 4 liters of oxygen at 86%. Jugular venous pressure, 16 centimeters of water. She has an abnormal heart sound. That's the S4 gallop. That's what you're looking at there. She has a history of an aortic stenosis. Ooh. So that's back pressuring the left ventricle. So I'll give you that hint there. Also, so this is her cardiac silhouette you're looking at there. Labs, elevated creatinine. So that tells you about her kidneys. This is why paying attention to patient assessment is important. And lactate is within normal limits on this patient. So would this be more of a hydrostatic or ARDS patient, right? Hydrostatic, as far as when we're looking at this patient, would be cardiogenic. So hydrostatic equals cardiogenic. Pulmonary edema. So this patient would be more of a hydrostatic, right? Not risk factors like sepsis. Sepsis is the #1 cause for ARDS. So no clear ARDS risk factors. So, and her distended neck veins or jugular venous distension is indicative of elevated right-sided heart pressures. That's why it's important to sort of pay attention to little things like that when you're looking at all this. Hopefully these things are starting to help you, right? Sort of start to see where all this comes together at the end.